All right. Good evening again, everybody. So today, what we're going to cover today will be, as announced, cardiomyopathy. Cardiomyopathy. Now, first thing first. Before we go into details on cardiomyopathy. Wait 1 second. I need to get my before we go into details on cardiomyopathy. First, I would like us to understand the term cardiomyopathy first. The term cardiomyopathy. Yeah, it is not a diagnosis. The name itself, cardiomyopathy, but it is just an umbrella term or a reference point when we talk about diseases that affect the myocardium. The name cardio means that it's the muscles of the heart. Pathy means pathologies, right? Patho. Also remember that this only refers to groups of diseases that affect the myocardium. Diseases that affect the myocardium. It is not in reference to any pericardial diseases or any endocardial diseases, and this is specifically for for the myocardium. And this term, what we've learned before, we've learned myocarditis, right? When we talk about the inflammation of the heart, we talked about myocarditis, and the disease itself, the disease itself, myocarditis, also falls under cardiomyopathy. So it is not only when we talk about cardiomyopathy, it is not always in reference, not always, but it can be most of the time in reference to the main ones, the ones that we all know, hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. But we need to bear in mind that the term cardiomyopathy itself, it's not, it is still an umbrella term in reference to any diseases that affect the myocardium. Okay, so with that said, when it comes to a term or a group of diseases, it means that there there's always a reference point to it as well. What I mean is etiology. So it can be primary or it can be secondary, right? So primary, as we all know, primary, it's most of the time something that is maybe congenital or genetic, or mix, or something that is acquired, or what it simply means is that primary, it means that it affects the heart in itself. Whereas secondary means that it is just it is a result of another disorder or another disease. That's what primary and secondary usually means, right? So uh, with that said, with that said, although we all know that the main cardiomyopathies, whenever we talk about cardiomyopathy, is hypertrophic cardiomyopathy, dilated cardiomyopathy, and also restrictive cardiomyopathy. Although these are the three known ones and diseases that we can actually put as diagnosis, but there are so many other diseases that still fall under this umbrella term, besides three of them. We're not going to we're not going to go through all of them, because if we want to go through all of them, we are already working towards our specialty, cardiology specialty, and it is too deep for a simple 1.5 hour class. All right, so with that in mind, three already known, commonly known. What are other ones that are also under this term? First is something called arrhythmogenic right ventricular cardiomyopathy. That is a diagnosis. It's under the ICD-10, still under cardiomyopathy. Next will be something called stress-provoked cardiomyopathy or Takotsubo, Takotsubo, Takotsubo cardiomyopathy. Peripartum cardiomyopathy, or this can also fall under dilated cardiomyopathy, whichever it is. Brugada's disease, Brugada's syndrome. We're not going to go to, we can talk about it maybe in the future. It is quite specific when it comes to ECG finding and all that, but that's a story for a different day. Okay, there's so you can read up on them. There's a lot of diseases that fall under primary cardiomyopathy, and secondary cardiomyopathy can be a lot too, which we are going to cover today too. And we will understand how some diseases can cause some of these major cardiomyopathies that we are going to talk about today.
Norman,
Mm.
what is the last name you told?
Takotsubo,
No, something start from B.
peripartum,
No, after that.
Brugada's,
Brugadas. Okay.
Brugada, Brugada syndrome or disease. Okay, with that said, let's start talking about the main cardiomyopathies that we know. Okay, the hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive cardiomyopathy. The rest, you can read them up yourself. All right, let's first talk about hypertrophic cardiomyopathy, HCM, hypertrophic cardiomyopathy. So from the name itself, it suggests that the myocardium is thick, right? It undergoes hypertrophy. It is hypertrophic. It is thick, and it will cause some problems, of course. Now, before we go into all of this, I told everybody some pointers that I would highly encourage everybody to revise, and that is the treatment or just heart failure in general. Simply because these cardiomyopathies will most often lead to heart failure, and the way you treat heart failure will fall under this. So treatment of cardiomyopathies, roughly they are almost the same. Even diagnoses, roughly they are almost the same, because at the end of the day, the symptoms are heart failure symptoms. But of course, there are some specific ones that we are still going to discuss today. All right. With that said, remember last time when we talk about heart failure diseases. Heart failure is basically divided into systolic heart failure problems because of the systolic dysfunction, and problems with diastolic dysfunction. Yeah, I hope everybody remember that. And I can confirm that because I wrote down what the points that I wanted to that I thought earlier on. Systolic and diastolic, and we are going to talk about which which cardiomyopathy will fall under systolic, which cardiomyopathy will fall under diastolic. Because remember when we talked about treatment of heart failure, the treatment, the most specific, the treatment that we always give will only help for diastolic heart failure. And however, it is unfortunately there's no specific treatment, or there's no effective treatment for systolic heart failure, but only for diastolic. And for systolic, it's mostly symptomatic, which means we only give diuretics, and if there's any problems that arise, like maybe arrhythmias, then we treat the arrhythmia. But specific treatment, for example, specific treatment for diastolic heart failure, for example, your ACE inhibitors and all that, and how we talked about how to prescribe ACE inhibitors, yeah, right? And how to prescribe beta blockers and all that. Those fall under diastolic heart failure and not systolic, right? Okay, so let's go back to hypertrophic cardiomyopathy. Let's go back to hypertrophic cardiomyopathy. Um, it is often confused, or it is often assumed by students that in valvular heart diseases, whichever valvular heart diseases, aortic stenosis, mitral stenosis, regurgitation, and whatnot, there's always some form of hypertrophy of whatever chamber it is, right? And people will assume, students will assume that because these walls have undergone hypertrophy to compensate for the changes for the hemodynamic changes in the heart, that means that um, the the patient might have hypertrophic cardiomyopathy. That is a false assumption, because although it is still the heart walls are still going through some form of hypertrophy, but that is because it is secondary to valvular heart diseases, and your diagnosis should be that specific valvular heart disease, for example, aortic stenosis and whatnot, and not hypertrophic cardiomyopathy. Understand? Now, second point that I would like to clarify is that hypertrophic cardiomyopathy, it is a congenital disease. It is genetic. It is autosomal dominant. It is an autosomal dominant disorder of the muscle tissue, which causes defects in the genes that encode for the contractile property of the myocardium. And by specifically the contractile proteins that are responsible for the contraction of the myocardium. And these proteins are called beta myosin, alpha troponin, and troponin T, that we measure for cardiac enzymes. Remember? Yeah. So because there are some mutation in the genes, and it is an autosomal dominant disease, so very often it is uh, it is it happens in young patients instead of elder patients that we see most often in valvular heart diseases. You see the difference in group of patients. So that is why we cannot assume that the hypertrophy that patients, the hypertrophy that the cardiac hypertrophy that patients have in valvular heart diseases is the same as hypertrophic cardiomyopathy. Clear? Okay, so right. Uh, besides that, when we talk about hypertrophic cardiomyopathy, it is divided into two. And initially, it will start with first one, and it can lead to another one, and which I'm going to talk about now. Now, the first one is called non-obstructive hypertrophic cardiomyopathy, or simply put, just hypertrophic cardiomyopathy itself. And it is non-obstructive.
Is this a classification?
Yes,
Okay.
yes. It is non-obstructive cardiomyopathy. Or if you don't want to use non-obstructive, just hypertrophic cardiomyopathy is fine too. It's fine already. Another one is called hypertrophic obstructive cardiomyopathy, or HOCM in short. Some Americans call it HOCM. I don't know why. HOCM. MRSA, HOCM. These people and their pronunciation, their pronunciation of abbreviations. We're going to talk about the difference between both of them. Okay, the cause is also the same for both. It's genetic causes. They are all genetic causes. I need to differentiate both of them. I need to show you a picture. How do I share screen? Okay. All right. I hope everybody can see this picture. It's not very clear. It's a very small picture. So when I zoom in, it looks very pixelated. Anyway, the one on the left here, the one on the left is hypertrophic cardiomyopathy, and the one on the right here is hypertrophic obstructive cardiomyopathy. Now, what's the difference between both of them? You see, both of them, the myocardium has already undergone cardiomyopathy. But the problem with obstructive cardiomyopathy is that this part over here, specifically the intraventricular septum here, becomes too thick, extremely thick, that it starts to block the aortic valve here. It starts to compress the aortic valve, causing the aortic valve or the aortic orifice to become smaller. And it looks like aortic stenosis, but it is not aortic stenosis. The valves are working fine. The valves are working fine, just that the intraventricular septum is now compressing the aortic valve, causing the orifice to be smaller, thus thus obstructing the blood flow that is running through the orifice. That is why the term obstructive comes into the picture. Sometimes the obstruction can be so severe that the orifice can be completely obstructed, and it is an emergency situation. So from here, you see that we all understand that the process it's like a cascade process. Start with hypertrophic cardiomyopathy and can end up with hypertrophic obstructive cardiomyopathy. Okay. Clinical picture of or clinical the signs of hypertrophic cardiomyopathy. The signs for any cardiomyopathy, they are almost the same. They're almost the same. Common ones are syncope or fainting, chest pain or angina pain, palpitations, and you can hear pathological heart sounds like S4 or pathological S3. Dyspnea also can occur, of course, and any clinical manifestation of of heart failure. But remember, heart failure can be left-sided and right-sided, yeah? And clinical manifestation of both left and right sided heart failure, they are different because both sides of the heart, they are connected to different things, right? Example, if in left heart failure, knowing that the left ventricle will have to perfuse your tissues, and if it fails, it means that the blood is not going out and it is pulled in the lungs, right? So we see copulmonale or pulmonary edema. So we can hear rails, we can hear moist rails, we can hear wheezing and stuff, and the patient can complain of cough, or it's the most characteristic cough is the pinky foamy cough. Whereas in right-sided heart failure, we see more of pedal edema, more of cyanosis and stuff like that. So that's left-sided cardiomyopathy, that left-sided heart failure. So that's science, right? But because hypertrophic cardiomyopathy is congenital or genetic, it is very often asymptomatic. And when it's already symptomatic, it means that it's either already serious or it's already in the obstructive form of hypertrophic cardiomyopathy. Now, why is obstructive cardiomyopathy very dangerous? It's because it is one of the most common cause of sudden cardiac death. We all know that the complication of MI, for example, can result in sudden cardiac death. And of course, that is very common, right? And this is actually your HOCM is actually your one of the most common cause of sudden cardiac death as well. And when it comes to cardiomyopathy, the most common cause of cardiac death is HOCM. Second is your arrhythmogenic right ventricular cardiomyopathy or dysplasia that I talked about earlier on, some of other types of cardiomyopathy. Besides sudden cardiac death, it also can result in fatal arrhythmias, your AFib, and of course your heart failure, right? Now, before we go into diagnosis and treatment, there are few things that we need to know that can increase the clinical manifestation. Oh, by the way, um, from my explanation before, from all that I've talked earlier on, which heart failure do you think this falls under? Systolic or diastolic heart failure, in your opinion?
Diastolic.
Diastolic. Anybody would think that it's systolic? No? Okay. If no, why diastolic?
Because the problem is when feeling of blood in the heart. So I assume it's diastolic.
Mm-hmm. Okay. You're right. Yeah. The problem is diastolic is because the heart, there's filling defect, correct? There's filling defect and ejection fraction is now reduced. Not ejection volume, not fraction. Ejection volume is reduced because there's now less amount of blood in the heart, this filling defect. However, it is not a systolic process. It is not a systolic heart if it falls under, if it develops into heart failure. It is not systolic heart failure because the heart is very, as I mentioned earlier on, is very thick, and it is it's hypercontractile. It contracts very, very strongly, and the systolic function of the heart is very rapid because the heart is now very thick. It's not that the myocardium is no longer functional just because it is genetically or it is congenitally thick, but it's congenitally thick or congenitally, if that's even a word, hypercontractile. It means the heart pumps very quick and very, very violent. So it means the ejection fraction Normal ejection fraction is about 60, 65, 70, 60 plus minus 5 or 75 around there. When it comes to when we measure ejection fraction in your echocardiogram, it is often elevated, about 80%, 90%, instead of about 60, 65, 70%, and that is normal. See, so understand now that when it comes to ejection fraction, we talked about when we talked about heart failure. Just because it's 60, 65, 70, it does not mean that it's not good. You know, when we do test our exams and all that, and 60, 65, 70, 3 pass, was 80, 90, 95, 100 off 5 piat. No, just because it's about, it looks about average, it's actually normal. When it's high, 80, 90%, it's actually abnormal. So it's abnormal in your hypertrophic cardiomyopathy. All right, so before we move on, we need to understand a couple of things that can increase the problem or clinical manifestation of your hypertrophic cardiomyopathy, specifically your HOCM. Specifically your HOCM, how to what can increase the obstruction and what can decrease the obstruction, right? So both, of course, it can be physiologically increase of or decrease, and some of them are pharmacologically they pharmacologically can increase and pharmacologically can decrease as well. So let's talk about when it comes to myocardium. First, let's talk about contractility of the myocardium, right? Because that's the one of the big function of the myocardium. So what increases contractility? When contractility increase, it means that it also increases the risk for obstruction too, right? Of course, when it pumps very quick, the intraventricular septum will also automatically close the aortic orifice, right? So what can cause that? Of course, physiologically, tachycardia can cause, right? Cause that tachycardia. We other causes can be your, so before you go that, so from the logic itself, tachycardia, we understand that whatever it is that can cause tachycardia can increase contractility and also increase your obstruction. It means that your when it comes to drugs, we talked about cardiotropy, right? We talked about inotrop. What is inotropic effect? What is the five um, cardiotropy, right? Positive inotrop, negative inotrop, and what your positive inotrops will definitely increase your contractility. It means that your digoxin, your digitalis, your glycosides can increase your contraction. Your beta agonist, for example, your epinephrine, norepinephrine, can increase contraction, of course, and some arrhythmia as well can increase contraction. For example, your extrasystole. So these are the things that can increase contractility. All right. Second is preload. The term preload and afterload. But before we go to preload, let's talk about before we go to afterload, let's talk about preload first. So preload, can somebody tell me what preload is? We've talked about this before. And I remember Polycarp asked me what is preload. All right, let's ask Polycarpo. Ogapi, are you there? What is preload?
Yes, I am.
Mm.
I'm trying to remember how you, I understand, but I'm trying to remember how you put it then.
You understand it?
Yes, I said I understand it. I'm trying to remember how you put it. But can I put it in my own terms?
Sure, of course, of course.
Can we talk about uh, the contraction before the contraction before the okay, the okay, the initial contraction, right, before the oh, the initial, okay, the initial contraction before the something initial, right? Something initial.
Okay. Yeah, the logic is there. Yeah. Yeah, you're
Yeah.
right. The logic is there. It
Yeah.
is the amount of stretching that the
Okay.
myocardium will have to stretch, the tension that the myocardium will have to stretch in order to hold all the blood in full volume.
Okay.
That's preload. The term load here refers to the amount of blood in the ventricle, full amount of blood in the ventricle, pre and after load. Load means that amount of blood. So preload means that how much that the myocardium can stretch in order to hold the blood in the ventricle, whereas afterload is the amount of force that the myocardium will have to push, the resistance that the myocardium have to push to empty the ventricle. That's afterload. Preload is also synonymous with end diastolic volume, the same thing. End diastolic volume or end diastolic pressure, the same term. They are just trying to create fancy terms for the same logic. Okay, so with that said, what are the things that can reduce preload, and why is reduction of preload, why can reduction in preload cause increase in obstruction in hypertrophic obstructive obstructive cardiomyopathy? It's because you know that the myocardium is now very thick, right? And there's already very limited space for blood to go in. Imagine this room of mine. This room of mine is with furnitures. For example, what if I'm a hoarder? You know, some people that they like to hoard things because they're very sentimental and all that. So it's very difficult for me to move around the room, right? It's very difficult for me to move around the room. So because of that, because of that, uh, it means that there's not much that the heart will have to pump. There's not much pressure to push the myocardium that is already thick so that it normalizes. The thing is that it is good when the ventricles are filled a lot, because it pushes the ventricles so that it normalizes. For example, if this room is very full right now and I need space, I will have to forcefully push things around to make room, right? So what are the things that can reduce preload? And if your preload is increased, it means it's good. It's actually a good thing. But if your preload is reduced, if your preload is reduced, then it's a problem. Now, what can what can decrease your preload? It's something called Valsalva maneuver. One of them, Valsalva maneuver. And if we want to hear the murmur, especially during your hypertrophic obstructive cardiomyopathy, because as I mentioned earlier on, it is it looks almost like aortic stenosis, right? Because the intraventricular septum is now compressing the aortic orifice. It looks like that. So we would expect the same murmur that we hear in aortic stenosis. Now, can anybody remind me what kind of murmur that we hear in aortic stenosis? We talked about it.
Systolic murmur.
Systolic murmur, okay. And what is the characteristic of that murmur? Decrescendo, crescendo, or any? Are there any snap?
I'm not sure about that.
Okay, it's okay. The people who were in the
Crescendo.
valvular class.
Crescendo.
Crescendo,
Do.
crescendo,
Di,
and
di screen. Di screen.
decrescendo. Crescendo,
Yeah.
decrescendo, or the diamond shape murmur, right? It increases, then it decreases. We're
It's
not going to
not the
go.
diamond shape.
What?
It's not the diamond shape.
It's not diamond shape. What shape is
Yeah.
that?
I mean, like for aortic stenosis, I don't think so. It's the diamond shape.
Then what is it?
I don't know. I think the diamond shape is for regurgitation.
Regurgitation. Which regurgitation? Aortic regurgitation.
Mitral, I think. But I'm not sure.
All right. If you can go and check again, um, because as what I remember teaching aortic stenosis, it's crescendo, decrescendo, and if I was wrong, you can
Okay.
let me know too.
Okay. I think I'm wrong.
Well, we're all learning, so it's fine. But anyway, the one that I know at least is systolic, correct? Systolic crescendo decrescendo murmur that you can hear on your right upper sternum, second intercostal space, because that's your aortic valve, right? So that's where you can hear it. So if you want to provoke that murmur, you can perform Valsalva maneuver so that you can hear it. So what's Valsalva maneuver? I think everybody knows Valsalva maneuver. If not, you close your nose, then you forcefully blow out, force. And what that does is that it simulates your vagus nerve, and also then no, not vagus nerve, your carotid sinus, right? Carotid sinus. Then that decreases the heart rate. In other words, it decreases your preload. It decreases your preload, and it can provoke that murmur, and you can hear it. So that's one of the ways to hear that murmur. Besides that, pharmacologically, what can reduce preload? They are your nitroglycerin, they are your vasodilators, like hydrazine, your calcium channel blockers, your dihydropyridine calcium channel blockers, not your non-dihydropyridine, your dipines. Why can this reduce preload? Not because it affects the heart, but because your peripheral vessels are now dilated. There's no need for the heart to pump that much anymore. So there's a reduction of blood inside the ventricle, and thus reducing preload. So what can increase preload is, of course, high volume of the heart, right? High volume of blood, so of the heart, high volume of blood in the ventricle. So if the patient drinks a lot, very good hydration and all that, the intravascular volume of the blood, it increases. It increases, Bradycardia can increase volume of the heart too, because the heart does not have to pump that much. And your beta blockers. Beta blockers, you know, that it reduces your heart contractility. They are negative inotropes, yeah, and your blood volume gets to increase as well. So these are ways to increase your preload. What else that can increase preload? Sedation can increase preload. You know, sedation can result in bradycardia. Anesthesia, anesthetic drugs can also increase preload. And yeah, so those are the drugs. Basically, negative inotropes can increase preload, whereas positive inotrope can reduce your preload. Same goes to afterload. Afterload. Oh, I forgot to mention, besides hydration, the patient drinking a lot of blood, or a lot of blood, a lot of water, uh, diuretics. You know, diuretics, it flushes blood, flushes water out, so that can cause reduction in preload, and also, yeah, they can increase obstruction too. So the logic is also the same as afterload. Reduction in afterload can also increase in obstruction. The same set of things that we've mentioned earlier on, your nitroglycerin, your dihydropyridine calcium channel blockers, your hydrazine, basically your vasodilated drugs, and your beta agonists, your epinephrine, norepinephrine, all those things that can increase the dilation of the peripheral vessels. Those can reduce afterload as well. Whereas the opposite, increase afterload, they can, well, decrease the obstruction. So everybody understand, right? So these are the three things that three factors that can affect the obstruction: your contractility, preload, and afterload. Okay, clear?
I have a question.
Mm-hmm.
The diuretic can cause a reduction on the pre and on the after load,
Yep.
like on both.
On what?
Can it cause both on the pre and on after load?
Yes.
Okay.
All right. If there are no other questions, let's talk about the diagnosis, right? The diagnosis for cardiomyopathy, for any cardiomyopathy, they're the same things that you do. You do, of course, your echocardiogram. The same thing. Every one of them, the gold standard is your echocardiogram. But of course, there are differences in findings of echocardiogram that differentiates each of this cardiomyopathy. So in hypertrophic cardiomyopathy, you see that the walls are thickened asymmetrically, and that the left ventricles, most of the time, the left ventricle is thicker than your right ventricle. Next, for your HOCM, echocardiographic changes in HOCM. Of course, as we all understand, that it still fall under the same disease, right? Hypertrophic cardiomyopathy, but because now it's obstructive, then some of the changes might be different. So echocardiographic changes, there is an acronym for it. It's called Mr. Sam Ash. Mr. Sam Ash. We'll go through one by one. Mr. MR. We will see mitral regurgitation. Mitral regurgitation. That's what it is. SAM, S-A-M, systolic anterior motion of the anterior mitral valve. leaflet. Now, what does this mean, Sam? And systolic anterior motion of the anterior leaflet of the mitral valve. The sentence itself is very loaded, yeah? All right, so let's break it down one by one. Let's talk about the mitral valve itself. The mitral valve itself, it has two leaflets, the anterior leaflets and the posterior leaflets, whereas the other valves, let me show you. The other valves, they have three leaflets, while your mitral valve is the only one with two leaflets. See here? Aortic has three leaflet, pulmonic three leaflet, tricuspid three leaflet. See the orientation: anterior, left, right, posterior. And your mitral over here, your anterior one and your posterior, A and P, right? Okay, so understanding now that we all understand that mitral valves has two leaflets, it means that it's like this, like this, right? So from the sentence, there's now systolic anterior motion of the anterior leaflet of the mitral valve. It means that the anterior leaflet is now the problem. Okay. Now, what is systolic anterior motion? Systolic anterior motion. Now, during diastole, or the movement of the valve itself, it's like this, right? It opens, then close, opens, then close, opens, then close. Yeah. If two leaflets anyway. Now, let's say this is the anterior leaflet. So what happens is that when it opens, okay, normal. But when it closes, it does not touch each other. This one over here, it goes the extra mile and go like this. So it goes like patoop, patoop, patoop. So some of the blood can actually, a little bit can leak into the atrium. So let me show you a picture. Hopefully it's clearer. See, on the left side is your normal leaflet. Now on the right side is when your leaflets are the same. It's what the systolic anterior motion is. So you see here, it closes, then this one over here, zoop, goes the extra mile to move up. So this is what it means. Understand, yeah? So that second point, SAM, systolic anterior motion of the anterior leaflet of the mitral valve. Now, second, ASH, asymmetrical hypertrophy, ASH. The same like your findings in hypertrophic cardiomyopathy. So, but for HOCM, these are the three characteristic ones. All right. Let's see if I missed out on anything. All right, so next will be, of course, when you talk about the heart, of course, you need to do your ECG, right? ECG means that in ECG finding, you can see left ventricular hypertrophy changes in your ECG. Can anybody remind me if it's left ventricular hypertrophy, what changes do you see in your ECG leads? Especially left ventricular hypertrophy. What changes and where do we see it? People, we discussed ECG already.
Peak R wave in V1 up till V3.
V1 to V3, peak R wave. What is deep S then? Does it fall under the same thing? Do we see deep S in when left ventricular hypertrophy, especially in V1, V2, V3? Yeah, the leads are correct. Yeah, V1, V2, V3.
Yes.
Okay. So you see tall R waves and also deep S. Tall R waves, deep S, ECG changes for left ventricular hypertrophy. All right. So these are all just the standard ones. Of course, you have to do your standard tests as well, your blood analysis and stuff like that, your liver function test and stuff. All those the routine ones, of course, you have to do. But what's specific for your hypertrophic cardiomyopathy is your echo, of course, number one, and your ECG, right? Okay. So management, how do you treat a patient with hypertrophic cardiomyopathy or HOCM? They fall under the same thing. There's also an acronym for it, A, B, C, D, E. A, B, C, D, E. A, amiodarone, because patients typically will have arrhythmias. B, beta blockers, because you want to increase preload and afterload as well, but mostly preload. And also beta blockers, of course, we prefer cardioselective beta blockers. Yeah, can anybody remind me which ones are cardioselective?
Metoprolol succinate.
Bisoprolol,
Name something starts
ne,
from next.
ne, vi,
Prolol.
nevibilol, nevibilol, and your cardivolol. Three cardiospecific beta blockers. So besides beta blockers, of course, you can also give calcium channel blockers as an alternative, right? Yeah, but like as usual, if it comes to the heart, you have to give non-dihydropyridine calcium channel blockers, which means they are your verapamil and that diltiazem, right?
So Nauman,
Hmm?
if we're giving beta blockers, we shouldn't give calcium channel blockers.
It really depends on the symptoms too. If it's heart failure, of course, heart failure, we start with ACE inhibitors first, right? And then you can then give beta blockers and then calcium channel blockers. If it's indicated, if beta blockers is enough, then okay, it's enough. If it's not enough, we can top it up with your verapamil or diltiazem. Okay. So that's B. A, done. A, amiodarone. B, beta blockers. C, cardioversion or defibrillator. C, cardioversion or defibrillator, whichever it is. But most of the time, cardioverter. Please remind me to send you a table that differentiates cardioversion and defibrillation. Okay, remind me. Also remind me when we talk about restrictive cardiomyopathy, again, remind me to talk about, when we talk about restrictive cardiomyopathy, remind me also to talk about constrictive pericarditis too, right? Okay. C, cardioversion defibrillator. D, dual chamber pacemaker. Dual chamber pacemaker. So what does that mean? Dual chamber, two chambers. If there are two chambers, of course, there's one chamber, single chamber. If there's one chamber, there's two chamber, it means there's also a three chamber, correct, right? Or four chamber, maybe, because we have four chambers of the heart, right? Okay, so dual chamber pacemaker. So from the name itself, it means that if it's single chamber pacemaker, it means that the lead for the pacemaker is placed only in one chamber, or that chamber specific for that disorder, whatever disorder in the heart. Dual chamber, it means it's being placed obviously in two chambers. Three chambers, or in other words, the typical name for this is your cardiac resynchronization therapy, CRT. We talked about this when we talk about heart failure, yeah? And we talk when all pharmacological treatment is not effective, we need to do surgical treatment or the insertion of pacemaker, which is what we talked about earlier on, cardiac resynchronization therapy, which means we are inserting three leads in three chambers. Commonly your left ventricle, right ventricle, left and right ventricle, and your right atrium. That's three. But dual chamber. Understand from what we've talked about earlier on, it affects most of the time, it affects the left ventricle, right? So it really depends on the specialist, the cardiothoracic surgeon or the cardiologist. If it's better to insert the leads in left and right ventricle, or your left ventricle and your left ventricle and your left atrium, whichever it is. The cardiologist or the cardiothoracic surgeon will decide on that. It's not as a normal doctor who is not a specialist yet. We just need to know dual chamber pacemaker. They just send them and insert the lead somewhere else. That's the problem. But if you, of course, if you are a specialist already, you need to know how to decide that. But anyway, that's D, right? E, endocarditis prophylaxis. Endocarditis prophylaxis. Remember when we talked about infective endocarditis, we talked about the importance of the prophylaxis as well. When do we do them, right? Remember, we perform prophylaxis on specific groups of patients. Remember, we talked about patients with native valves and patient with prosthetic valves, right? Remember, and so in this we need to perform prophylaxis for endocarditis too. We have to give antibiotics. All right, so A, B, C, D, E. These are this is the treatment, the management for your HOCM or hypertrophic cardiomyopathy. Drugs to avoid. We must avoid, as we talked about earlier on, we must avoid nitrates. Although it's very tempting to give nitrates. ACE inhibitors, actually. Remember our heart failure, our first line is ACE inhibitor, right? But unfortunately here we can't give ACE inhibitor because it affects the peripheral artery too. And it's, yeah. Your positive inotrope, any positive inotrope, and your digoxin too, because it can provoke tachyarrhythmias, digoxin. So these are the drugs you have to avoid. All right. So done so far for hypertrophic cardiomyopathy. This is just like on yeah.
Question. You said endocarditis prophylaxis. I don't understand why. Where is the window for a potential infection?
Where's the window for potential infection?
Yeah, in hypertrophic cardiomyopathy.
It's because you see the leaflet of the aortic leaflet is now affected. Remember when you talk about HOCM? So although probably the endocardium is intact, remember we talked about how some changes in level in the three layers of the heart, but although it can be assumed, of course, that can happen. Of most of the time, the endocardium is intact and not inflamed. That's why prophylaxis is needed. And because now that the aortic valve is affected because of the increase in the thickening of your intra ventricular septum, because of this, there are now hemodynamic changes in your, especially as it goes through the aortic orifice. Because of this, any infection, not that we are looking at for an entry of infection. We don't. The thing about prophylaxis is that we want to prevent something, right? So sometimes some of the things we don't know what to prevent, or we cannot identify what to prevent. So if there is something to protect, something to prevent, if it happens because of the changes in hemodynamic, let's say some form of, if the patient has, I don't know, otitis media or something, that the bacteria that can cause some form of bacteremia and all that, and it flows in the blood, and now that the hemodynamic, the patient is hemodynamically unstable, so we need to prevent that, simply because the aortic valve is affected. Okay.
Okay, thank you.
All right, sure.
Mm.
All right, now that we've covered that, it's only hypertrophic cardiomyopathy. Let's move on. If there are no any questions anymore, let's move on to dilative cardiomyopathy, dilated cardiomyopathy. Now, dilated cardiomyopathy, most common cause of dilated cardiomyopathy is idiopathic. We don't know what causes it, but if we can identify a cause, it will be alcoholism, a lot of alcohol drinking, and it can also happen in pregnancy, peripartum. We're not going to go into great details why it happens during pregnancy. If you would like to know, you go back to your ops class number 1, ops changes, physiological changes in pregnancy, and you understand why dilated cardiomyopathy can occur in pregnancy. Next will be hypertension. If we can identify a cause, hypertension. Remember when we talk about hypertension, there's an target organ, right? And once that happens, the most common one will be dilated cardiomyopathy when it affects the heart. So what happens here? Here, the heart is dilated, not because the walls are thick, but because there's just the walls are thin, and the chamber of the heart, they are big. What causes it? Like I said earlier on, we don't know. Now, because of this, there is again impairment of contractility. The most common problem in dilated cardiomyopathy is inability to contract. The problem is not the dilation. The dilation is normal. In fact, it's not affected at all. So the problem is your systolic problem. Okay, why is this showing? So because of this, now that we understand that it is a systolic problem, so if it results in heart failure, it is a systolic heart failure more than diastole. And like I mentioned earlier on, unfortunately, there's not much we can help when it comes to systolic heart failure. So most of the time we give symptomatic treatment. We give your diuretics for furosemide, your thiazides, your spironolactone, and whatnot. However, you can try to give the same set of drugs for diastolic heart failure, your beta blockers, your calcium channel blockers, but uh, that it, it might help in the long run, probably might help in the long run, but then again, the problem is not the relaxation of the ventricle, but the problem is a systolic problem of the ventricle. Signs and symptoms are the same as like we said earlier on. Ejection fraction can be low, very low, can be very low, because the heart cannot pump anymore. The walls are thin. In echocardiogram, the walls are thin and the chambers are big. Chambers are big. So aside all of that, aside all of these points that differentiates it from hypertrophic cardiomyopathy, this is just what dilated cardiomyopathy is, right? Signs and symptoms are the same, but what distinguishes it? What distinguishes it is the etiology, unknown, alcoholism, pregnancy, or hypertension. The walls are thin, but the chambers are enlarged, ejection fraction reduced, and it's systolic problem. Treatment is the same. Treatment, yeah, roughly about the same, but of course we treat based on systolic problem, systolic heart failure. Right. Before I forget, about hypertrophic cardiomyopathy. When it comes to surgical treatment, because the walls are thick now, right? So you can try to reduce the thickness of the wall. So surgical treatment, if you're interested in the surgical treatment, is catheter. It's called catheter septal ablation or myocardiectomy. I don't know exactly how they work. If you're interested, go ahead and read up on them. Okay, so back on dilated cardiomyopathy. If you have no other questions anymore on dilated cardiomyopathy, can we move on to restrictive cardiomyopathy? I know it's a bit short, but most of the points we've already talked about them in hypertrophic cardiomyopathy. No questions? All right. All right, let's move on to restrictive cardiomyopathy. Restrictive cardiomyopathy. So from the name itself, it suggests that the problem is due to the myocardium being rigid. You know, like when we talk about pulmonary diseases, there's obstructive diseases and there's restrictive diseases, right? Obstructive and restrictive, right? Correct. Obstructive and restrictive. The same thing here. So restrictive, it mostly refers to the rigidity of the myocardium, inability of the myocardium to really become very elastic, like a rubber band. It's supposed to be like a rubber band, but it's an old rubber band, so it does not it's not elastic anymore. Even if it's elastic, it cannot go back to its normal state, right? So what can cause what can cause restrictive cardiomyopathy? It really depends on region, but most of the causes is something that infiltrates into the myocardium, something that disrupts it, something foreign that goes into it. In the US, based on the USMLE material, it says the number one cause in the US is sarcoidosis. Sarcoidosis is a disease, it's a multi-systemic disease where there are formation of granulomas, immune granulomas in those organs and causing it to be dysfunction. So here we can see those granulomas in the myocardium. So number one cause in the US is sarcoidosis. However, in the in the in this in the UK, the most common cause is amyloidosis. Amyloidosis. If you're interested to read up on amyloidosis, there are different types of amyloidosis. It's a very long topic to talk about. It's AA amyloidosis and stuff like that. It's therapy 5th year amyloidosis. But this type of amyloidosis that can cause restrictive cardiomyopathy is secondary to myeloma, and because it's secondary to myeloma, it causes amyloidosis. Another one is hemochromatosis. What does this mean? It means that there is deposition of ions, or deposition of iron in the tissue, right? So this, you can see iron in the myocardium. Next is scleroderma, systemic scleroderma. And again, if you like to know about systemic scleroderma, you can read up on it. This also is therapy 5th year. Therapy 5th year. We talked about 2 different types of scleroderma, right? But anyway, it's an autoimmune disease. It's an autoimmune disease, and it causes the increase of formation of connective tissues in different parts of the body, unfortunately in the myocardium here. So yeah, these are the common ones. There are some other ones that are not that common, but that it also falls under the same picture. So clinical manifestation, they are the same. They are the same, and the same for all. And the heart, if it develops into heart failure, it is both systolic and diastolic. So good news, now that it's both systolic and diastolic, so it means when you treat this, it will actually help. It will actually help because it's both. All right. Before we differentiate restrictive cardiomyopathy and constrictive pericarditis, that is, let me see if I missed out on anything. Besides, yeah, I did miss out on something. The etiology, besides sarcoidosis, amyloidosis, hemochromatosis, cancer, neoplasm also. There's any cancer that can that metastasizes into the myocardium, can cause that too, and radiation. All right, let's compare. Let's compare restrictive cardiomyopathy with constrictive cardiomyopathy, constrictive pericarditis. Remember, I said that another name for constrictive pericarditis is fibrinous pericarditis, where there's deposition of fibrin, connective tissues in the pericardium, right? on the pericardium or within the pericardial sac. And because of this, it looks like there's some form of, now that the heart is rigid. In other words, the heart is rigid. Just that the difference is that the problem in restrictive cardiomyopathy is that it occurs in the myocardium. However, in constrictive pericarditis, it occurs in the pericardium. So technically, pathophysiologically, they are just the same. They're almost the same. Clinical manifestation and your signs and symptoms, they're all the same. They are all the same. But the only way to even the treatment, if necessary, is almost the same. But remember, pericarditis, it's inflammation of something, right? Inflammation of the pericardium. So of course you can give NSAIDs and corticosteroids and corticosteroids. Then, but the only way to differentiate these two, of course, will be your biopsy. You just take a biopsy from your cardiomyocytes, and then your cardiomyocytes, and you see the difference between your myocardium and your pericardium. So the thing about biopsy is that it's not very common. So, and also it's also quite invasive, so people don't really prefer it. So what other things that can differentiate restrictive cardiomyopathy and constrictive pericarditis? In restrictive cardiomyopathy, you hear when you listen to apical pulse, your apical pulse, it's louder, it's very loud. And when you do chest x-ray in constrictive pericarditis, you can see little calcifications because it's an inflamed pericardium, right? And also fibrinous. So that inflammation can lead to formation of small little calcifications. So on chest, on your sonography, on your echo, you can see some calcification, or sometimes even in chest x-ray you can see calcifications. So that's in constrictive pericarditis, but in restrictive cardiomyopathy you don't see that. Of course, both of them, the heart can be enlarged, right? The heart can be enlarged, and ECG abnormalities, you can also see it. But the ECG abnormalities that we see in restrictive cardiomyopathy is we see in reduction in electrical voltage. So what does that mean? It means that the height of the QRS complex is not that high. The usual height for your QRS complex is about three or four big boxes, but in restrictive cardiomyopathy, the electric voltage is quite small. So you can see probably it might be does not even reach the one full box. So that can help you to point out that this is restrictive cardiomyopathy. Of course, it's not very specific and all that, but well, it just gives you some clue. But bundle branch block you can see as well, and sometimes maybe ST elevation maybe, but yeah, these are just not very specific. So treatment, we've already talked about it. Treatment, yeah, and of course the treatment, besides the symptomatic treatment, your diuretics and stuff, beta blocker, and treatment for cardiac failure, heart failure, as we talked about earlier on, what the common causes of restrictive cardiomyopathy means that you have to, of course, treat your underlying disease. Treat your underlying disease. I remember, who was it? I don't remember. Was it our immunology teacher or was it our animation teacher? When it comes to treatment, she always says, treat underlying disease, treat underlying disease. So the same thing in restrictive cardiomyopathy, treat besides the usual one, treat your underlying disease. If it's sarcoidosis, treat sarcoidosis. If it's amyloidosis, treat your amyloidosis. Okay. All right. So these are the main ones that are worth pointing out, worth talking. The rest, of course, is also worth talking. Just that it's very technical. Any questions so far? No? I don't think I forgot to mention any points. I think I've talked about all the points I want to talk about. All right. If no question, I hope today's class on cardiomyopathy is clearer, and I hope that everybody has a clearer picture of cardiomyopathy. Some of you might already have studied cardiomyopathy. Cardiomyopathy is actually a 5th year therapy topic, but if you're in 4th year, well, it's a good introduction to cardiomyopathy. You can continue to read up on cardiomyopathy. I've opened the therapy manual, the new one, of course, not the 2017 one. The new one, I think, it came out last year, and it's very extensive, and I'm just amazed by how by the load of information that they put in that manual. So if you would like to read up on it, sure, you can read up on it. And they also explain the arrhythmogenic right ventricular cardiomyopathy or right ventricular yeah, what's dysplasia, that right ventricular dysplasia in that manual too, if you are interested to read. So yeah, so that's cardiomyopathy for you, for everybody, for us today. All right, so no question. If no question, thank you so much. Have a nice evening.
Thank you so
You were
much.
supposed to share something with us, right? To show us a table or
All right,
something.
okay. I'll send it in the group, the table for what table was it again?
I forgot.
Differentiate between defib and
Uh-huh.
cardioversion.
Yes, the differentiation between defib and cardioversion. I'll also send you another table that that differentiates all of this cardiomyopathy for better understanding.
So what
All right.
are we having in our next class?
Next class. The plan was to talk about adult congenital heart defects.
Okay.
But if everybody's tired of talking about the heart, you can move on to GIT. Adult congenital heart disease. Congenital heart disease is mostly a pediatric problem, but as it happens in adult, it's called adult congenital heart disease. And I don't know, maybe it's worth talking. I've checked the European Society of Cardiology. They recently released a new clinical guideline for adult congenital heart disease. It came out last year. So because it's new, maybe it might be interesting to talk about it because it's updated. So what do you guys think? Should we talk about adult congenital heart disease
No
defects?
problem.
Yes?
I vote.
Okay.
I
Sangeeta,
got to.
all right. Aka, how are you?
I'm good.
Okay. So I hope you understand today's class.
Mm-hmm.
Understand